Welcome to this evening's program. We are privileged to have two expert speakers on this subject. Professor Ian Hickey, who's Executive Director of Brain and Mind Institute, Sydney Medical School, and Dr. Sebastian Rosenberg, Senior Lecturer, Brain and Mind Research Institute. Dr. Rosenberg was a public servant for 16 years, working in health in both state and federal governments. He was Deputy CEO of the Mental Health Council of Australia from 2005 to 2009, assisting in the publication of seminal Not-for-Service report in 2005, as well as other reports. He was also a consultant and a board member of Social Firms Australia. Its mission is to promote durable employment for people with a mental illness or disability. From 2009 to 2012, he was a member of the National Health and Medical Research Council's Prevention and Community Health Committee. He is a member of Sydney University's Health Policy Network and the Health and Work Research Network. Dr. Rosenberg.
Thanks very much, Joe, and thank you very much for the invitation to be here and to talk about this important topic. My job is really to set the scene for this discussion. Ian will discuss particularly the issue of teenage mental health, but we both thought that it was worthwhile to provide a brief overview of the state of mental health reform and to provide, I suppose, on that basis, some context for Ian's comments. So, as Joe pointed out, I've been involved with mental health since about 2005. In the period 2006 to 2012, there were 32 statutory inquiries into mental health conducted across Australia. 32 separate inquiries. One of my first roles as the Deputy CEO of the then Mental Health Council of Australia was to conclude and publish the Not-for-Service report, which Joe mentioned. And this report really concluded that the mental health system could be characterised as being in crisis. The 2006 report of the Australian Senate further confirmed this. It is my belief, nearly a decade on, that the key characteristics of this crisis in mental health remain. Well, one of the only things that really has changed is the political environment to support and sustain mental health reform has in fact dissipated. I would go further to say that real change seems more elusive than ever. So let me briefly describe the core characteristics of this mental health crisis. While mental health represents about 13% of the total burden of disease, it gets only around 5% of the total health budget. I don't think there's any particular reason that suggests that the funding should match the burden of disease. There's not an automatic one-to-one type correlation. However, I think that gap is very telling between the burden of disease and the amount of money allocated to mental health care in Australia. There have been only 2 surveys of mental health and wellbeing, both carried out by a now threatened and subversive organisation called the Australian Bureau of Statistics. The first survey was done in 1997, and of people who said they needed care for their mental illness in that preceding 12 months, only 38% of those people got any care. In 2007, when the survey was replicated, the figure was 35%, largely unchanged. So, to put it another way, of people who indicated they had a mental illness that required care in the preceding 12 months, 65% of people in 2007 got no care for that mental illness. I think the issue about that decade is when you think about 1997 to 2007, that was really a time when Beyond Blue began and a lot of initiatives around mental health and so on, and yet still that's not reflected in an upturn in access to care. I can talk a bit more about the Better Access program, and I will, and I think that's had an impact, and I'll get to that. But I think in terms of those survey results, it's very telling. So look, today's discussion focuses on young people, and I think it's, again, just worth understanding that unlike musculoskeletal disorders or cardiovascular disease, mental illness is really a young person's disease. 75% of all mental illness manifests before the age of 25. You probably heard Professor Macquarie talking about that during the Mental As on ABC. And failure to provide proper quality mental health care to our young people really therefore has lifelong consequences, and it risks condemning them to lifelong welfare dependence, failure to complete education, prolonged unemployment, and diminished or poor quality of life. And this represents, in my view, and I think in the general community's view, an incalculable cost, both to our community in terms of economic costs and in terms of social consequences, let alone, of course, the impact on the young people themselves. So given that mental illness is a young person's problem, it is particularly alarming that the rate of access I mentioned earlier on is particularly low among young people. Among young men in particular, who indicated, as I said, that they had a mental illness requiring help last year, only 13% of those young men got any care. 87% not in care. So I guess, thinking about it and trying to set the scene for what Ian will say about potential new ways of thinking and so on, what is it about our current mental health system of care, and I use that term very loosely, that makes young men not want to come? I should say, interestingly, the Australian Bureau of Statistics asked people why they didn't come. You said you had a mental illness that needed help. Why didn't you go? Would you like more information about services? About 90% of people said no. Would you like more information about treatments? And about 90% of people said no. Would you like more information about the illnesses themselves? And about 90% of people said no. So I need to tell you that on the basis of that, people like me have been told to shut up. What are you talking about? We ask them and they clearly don't want any assistance. These people do not wish to be helped. However, I really feel that these responses in the course of this survey really raise more questions than answers about our system. For example, did these people make the fatal mistake of getting sick on a weekend when treatment wasn't available? Did they go once before and find it such a distressing occurrence that they never wish to go again? Did they need psychiatric assistance in a language other than English? Now, there are a range of reasons why I think people may not come, and it behoves us to understand them in order to start to plan and design systems which would encourage people into care. Australia's situation is lamentable because it was a groundbreaker. In 1992, Australia became one of the first nations to devise a national mental health policy. Along with innovations such as community-based care and consumer rights, the first plan also made a point of calling for accountability. And again, I'm just referring back to our conversation here. Is teen health getting worse? Teen mental health getting worse? So can we tell? So they called for accountability, I guess, to really help us answer the question we're posing here today. The first plan was assessed by overseas experts after about 5 years and found to have made some progress, but not in the area of accountability. There was then a second national mental health plan, which was in place from 1998 to 2003, and again made commitments for independent and transparent accountability. The same overseas experts came back and evaluated plan number 2 and basically stated that it was still not delivering due accountability. In perhaps a policy wonk version of obsessive compulsive disorder, Australia then moved to establish National Mental Health Plan number 3. And in about 2009, the same experts, actually I need to clarify, it isn't actually the same experts, I think one of them may have actually died, but one certainly came back. I'm still working out how I can get myself a gig as an international expert. I was hoping, it's the only reason I'm staying friends with Ian actually. Anyway, the same experts came back and stated in their evaluation that national measures of progress in mental health were largely absent and annual reporting against agreed targets did not exist. They were particularly critical of the absence of any validated collection of the experience of care for mental health consumers and their families. So, despite calls made originally in 1992 for clear and transparent accountability, very little progress has been made. I guess I, in a reductionist kind of way, go back to the call which was made by Mary O'Hagan as the Consumer Commissioner in the New Zealand Mental Health Commission, and she said there were really only three things that you need to ask consumers. Do you have a house? Do you have a job? And do you have a date on Saturday night? And I'm afraid we can't measure any of those, nor education completion rates, nor even if someone is alive or dead 3 months after being in a mental health unit. Concern about mental health reached something of a crescendo in 2006 when Maurice Iema and John Howard placed the issue of mental health on the agenda of the Council of Australian Governments. As a Canberra boy, I couldn't help but be excited as this issue reached the Mount Olympus of political decision-making in this country. Sure enough, they committed some $5.7 billion of new money to mental health. A big sum. When you go from an M to a B, it's a big sum. And importantly, John Howard at the time made the following statement. Reform of mental health services cannot be achieved through a quick fix. It will require a sustained contribution of this magnitude from both the Commonwealth and the states and territories to ensure long-term fundamental improvements in services for the mentally ill. And together our investment in mental health will support reform of the system and ensure that it remains sustainable into the future. While COAG set out 5 key areas for action, in fact, states and territories could do whatever they wanted, in whatever order and to whatever magnitude. This reinforces the fact that the experience of care, your access and the quality of that care varies wildly depending on where you live. I believe this would be regarded as unacceptable in any other area of health, but is somehow okay in mental health. By far the largest element of the Commonwealth contribution to the Council of Australian Governments was to establish the Better Access Scheme, publicly subsidised access to psychology services through Medicare. Since November 2006, under this program, there has been 20 million billable occasions of service. There are only 23 million of us. Who of you has not been yet? This has cost more than $2 billion. The program now costs around $12.3 million each week. There was an evaluation done by the University of Melbourne in 2009, and you'll be pleased to know it was positive. It was helpful. However, it involved a very small sample of consumers, around 400 consumers, chosen by their service providers. Again, I guess I have to ask questions about whether that's adequate for us to feel, leaving aside the issue as a mental health advocate, even as taxpayers, as to whether we feel confident that this is a good spend. I have no doubt that it's making a huge difference in people's lives, but there may well be ways we can improve that program and ensure that it's providing better access to the right people. Despite the quote that I gave you from John Howard in 2006, subsequent COAG meetings really didn't deal with mental health. In 2011, Prime Minister Gillard and Treasurer Swan proudly announced mental health as the centrepiece of that year's budget, offering $2.2 billion, but over 5 years. This spending, which of course is really around $400 million each year, was directed mostly towards keeping existing programs going, though this was also the budget which announced the Partners in Recovery program. There has been no subsequent significant consideration of mental health by the Council of Australian Governments. Many of the programs established by the Commonwealth, such as Partners in Recovery and the Personal Helpers and Mentors program, are now slated for inclusion under new service arrangements associated with the National Disability Insurance Scheme, potentially withdrawing service from some existing clients. The Commonwealth, New South Wales, Victoria, Queensland, South Australia and Western Australia have now all turned recently to a new model of governance and administration in mental health, the Mental Health Commission. It is early days for all of these bodies. Western Australia is the oldest of the Mental Health Commissions and has only been going since 2010. But it is possible for us to set some criteria by which to assess their impact on generating new momentum for mental health reform. Is there more money? Are there more and better quality services? I frankly don't think that any of these commissions can yet clearly make these claims. So in a nutshell, Australia does not have the systems in place to properly account for mental health, to be able to tell whether what we're doing is actually making a lick of difference to people's lives. In lieu of this accountability, we run statutory inquiries, and these only serve to reinforce the sense of crisis surrounding mental health care in Australia, and I think importantly, to continue to diminish community confidence. I'll conclude with one last critical matter, and that is particularly in relation to expenditure by the states and territories. The vast majority of spending in mental health is hospital-based spending, either on acute inpatient care or hospital outpatient care. National spending on non-hospital mental health care would equate to only around 15% of our total spending on mental health, with the other 85% going on hospital-based care, including, I should say, the remaining psychiatric specialist hospitals which continue to exist around Australia. New South Wales has 5 such institutions still operating. Australia's lack of investment in non-hospital care and in genuine community-based mental health care has been so stark that it has left the debate open to those who call for a reopening of the psychiatric institutions. Care was better there, they say. Genuine mental health reform, in my view, does not lie here. It lies instead in new funding designed to rebalance our mental health system away from a medical model of hospital-based care and towards a recovery-based approach in the community. There are other ways of doing things. Trieste, a town in the north of Italy of about 250,000, has 7 acute care beds for a population of that size. New Zealand spends 5 times what we spend in Australia on non-hospital mental health care. We cannot afford to invest in old ways of working and old systems of care. I'll now hand over to Prof.